All right, welcome to The Explainer. Today, we are jumping right into one of the hottest debates in orthopedic trauma. How do we choose the right implant for fixing a femoral neck fracture? And to kick things off, let's just think about the scale here. By 2050, it's estimated that over 21 million people around the world will be living with disabilities from these fractures. That's a staggering number, and it really underscores why getting the fixation right from day one is just so critical. Okay, so here's how we're going to tackle this. First, we'll set the stage and understand the problem. Then, we'll introduce our three main players, our fixation devices. After that, we're going to pit them against each other, look at the evidence, and then, most importantly, we'll tie it all together into a framework you can actually use. So, let's talk about the challenge of the femoral neck. I mean, why is this one fracture such a big deal? Well, for starters, they make up more than half of all hip fractures. And, fixing them, it's a real clinical headache. The name of the game is getting that bone to fuse, right? We need what we call stable osteosynthesis, but we're trying to do this inside the hip capsule, an area that, as we all know, has a notoriously tough blood supply. It's a difficult environment for healing. And that biological tension is exactly why this whole debate, CCS versus DHS versus the new FNS, gets so intense.
All right, let's get to it. Time to meet the three primary tools we have in our arsenal for this fight.
So, first up, we've got cannulated compression screws, or CCS. You know them, you've used them. For years, they've been the go-to for non-displaced fractures. Why? Because it's a minimally invasive approach. But, and this is a big but, the trade-off is pretty clear. They've got weaker holding power and almost no angular stability, and that can be a huge issue when things get a little less stable.
And then we have the old faithful, the workhorse, the dynamic hip screw, the DHS. This thing is a beast when it comes to angular stability. It allows for that beautiful dynamic compression we want across the fracture line. Biomechanically, it's a tank. But you pay a price for that power, right? It means a bigger incision and more soft tissue disruption.
And this, of course, brings us to the new kid on the block, the femoral neck system, or FNS. The whole idea behind the FNS was to create the best of both worlds implant. Could we get the rock-solid angular stability of a DHS, but with the minimally invasive perks of cannulated screws? That's the promise anyway.
Okay, so we've met the players. Now for the main event. How do they stack up against each other when we look at the actual evidence? Let's dig in. And for that, we're going to lean heavily on this really important network meta-analysis from Frontiers in Medicine. This thing is a beast. It crunched the numbers from 23 different studies. We're talking nearly 56,000 patients. And what's so powerful about this is that it lets us compare all three implants directly at the same time. So first big takeaway, let's talk about function. When they looked at the Harris hip score, the data showed that the FNS group had a statistically higher score at follow-up than the CCS group. So on paper, FNS looks better. But, and this is where it gets really interesting, we have to look closer at that number. Yeah, it's statistically significant, but the actual improvement was just under 4 points. The thing is, the minimal clinically important difference, the amount of change a patient can actually feel, is way higher, like 6 to 10 points. So what does that mean? It means the patient themselves probably wouldn't even notice a meaningful difference in their day-to-day life. That's a huge piece of the puzzle. Okay, now what about complications? This is where the story of trade-offs really comes into focus. Look, the DHS is biomechanically stronger than CCS, no doubt. You see lower rates of implant failure and non-union. But, and it's a big but, it comes with a much higher risk of femoral head necrosis, probably from disrupting the blood supply during insertion. Now the FNS, this is where it gets compelling. It seems to give you stability that's on par with the DHS, while doing a much better job of preserving the femoral head. And this chart here really drives home those surgical trade-offs. What happens in the OR. If your number one goal is minimizing blood loss, CSS is still your winner, hands down. But look at the FNS. It kind of finds this perfect middle ground. It's a faster operation than putting in a DHS, and the data shows it leads to quicker fracture healing compared to CSS. That's a pretty powerful combination.
So after all that, what's the verdict? Well, there's no silver bullet, right? The evidence doesn't just hand us a single winner. It's much more nuanced. Which brings us to the most important question for any surgeon. How do you match the right implant to the right patient?
So what the evidence is really telling us is to use a tailored approach. It's about patient selection. The FNS really seems to shine in your younger patients with displaced fractures, where you need both that stability and you want to promote early healing. The DHS, it's still your go-to for those really unstable patterns where mechanical failure is your biggest enemy. And CCS? It absolutely still has its place for those stable, non-displaced fractures, especially in a frail patient where minimizing surgical trauma is everything.
Okay, but here's a massive warning label we need to talk about. A critical caveat. The analysis showed that the functional benefits of the FNS, they actually start to fade as patients get older. And even more worrying, some biomechanical studies suggest that in really bad osteoporotic bone, its stability might even be worse than 3 well-placed cannulated screws. So, you have to be really cautious when you're thinking about using this in your elderly population. And look, the FNS is still new. We have to be honest about what we don't know yet. There are urgent questions that need answers. For example, are we creating stress risers below the implant that could lead to future fractures? We just don't have the long-term safety data. And then there's the cost. This thing is more expensive, and right now, we can't definitively say that the extra cost is actually justified by better outcomes. These are big, unanswered questions.
So that really leaves us with the final question, the one we all have to ask ourselves in our own practice. You've got this promising new tech, the FNS, with some clear advantages. But how do you balance that excitement for innovation with the absolute non-negotiable need for robust, long-term evidence? That's the tightrope we walk every day, isn't it? And getting that balance right is how we ensure we're always advancing patient care as safely and effectively as we can.